It's technically we have one more minute until the afternoon, so I'll say good morning, everyone. This is Brandon Garrett, as you know, from the National Minority Quality Forum. It is the last Friday in July, so you know that means we're going to be talking to our team at SHC, Sustainable Healthcare, talking about some quality improvement measures and champions, I'm a little corny, with our champions for total health. And so with that, so we can have a good substantive conversation, I'm going to turn it over to our very own Kristen Hobbs, who's going to lead today's discussion. So Kristen, turn it over to you.
Thank you, Brandon. Thank you, everyone who has joined us today and who is joining us and stepping into our virtual webinar room. We love that you guys join us every single Friday at NMQF, but also for our SHC last Friday of the month webinars talking about the intersections of total health and vaccinations. So really quickly, I wanted to refresh everyone's memory and make sure that the new folks that are joining us understand how this webinar series came to be. So we've been doing a lot of work to increase vaccination uptake in COVID-19 and flu vaccinations with the CDC. And our communities wanted us to understand basically that they were sick before COVID and they will be sick after COVID. And we want to make sure that we are maintaining the trust that we are building in historically excluded communities. And so our webinars have transformed with the help of the Association of Immunization Managers and their iREACH team as our partners to include chronic illnesses and the intersection of vaccinations and how we mitigate our risk to ensure that all of our populations have access to their healthiest cells. So again, thank you so much for joining us today. Today we will be talking about hypertension and vaccinations. As Brandon said, I am Kristen Hobbs. I'm the Director of Quality Improvement and Equity at NMQF. So happy to be with you today. So just a few webinar notes before I turn it over to our very first panelists. Your audio and video capabilities are turned off just because we are in webinar mode, but the chat is available and we welcome respectful and honest communication in our chat box. So when we do get to our interactive portion where you will have a chance to give us some real-time feedback and assessment on our educational materials, please, please, please put your transparent feedback in that chat box. If you do have questions for our panelists, for NMQF, or myself, please use the Q&A functionality so that we can field those questions during the Q&A portion. So a little bit about our agenda. I'll tell you about NMQF and SHC, and then we'll dive right into our topic. So we'll talk about hypertension and lifestyle risk factors and risks of severe illness, and then we'll go into some vaccine data, recommendations. We were hoping to have our patient advocate perspective today, but we will not be having that, and that is totally okay. But there will be a video perspective on our microsite that you will get to preview later. And then we'll do our microsite feedback interactive portion and questions and answers. So really quickly about NMQF. NMQF was founded in 1998 by Dr. Gary Puckrin, an amazingly smart and talented human being, to reduce patient risk, using that as a vehicle for advancing and realizing health equity in historically excluded communities. And we're talking about all minoritized and marginalized communities, racial, ethnic differences, geographic differences, differences in physical and cognitive abilities, and the like. At SHC, we use the data that NMQF collects and maintains and supports to create sustainable, healthy communities in every single zip code. And we do that through quality improvement and clinical education and public health interventions. So you already know me, but let me introduce you to our president, Dr. Laura Lee Hall, and Chinny, who is my wonderful, amazingly talented colleague. She is our Quality Improvement and Equity Project Manager. She will also be helping me with this webinar today, and she will be taking notes during our interactive portion. So let's dive right in. Our very first panelist is Dr. Lawrence Sperling. He is the Executive Director of the Million Hearts Program for the Division for Heart Disease and Stroke Prevention at the Centers for Disease Control and Prevention, Center for Clinical Standards and Quality at CMS, and Katz Professor in Preventative Cardiology and Professor of Global Health at Emory University. Welcome, Dr. Sperling. So wonderful to have you.
Yeah, thank you very much, Kristen, and so glad to be here. This is a really, really important topic that we'll be discussing today on the webinar, and so glad that you all have framed this in terms of champions for total health. There could not be two more important topics that are impacting many, many populations that are vulnerable across our nation, beyond hypertension and the importance of vaccines. So if you'll go on to the next slide, I'm glad to be here on behalf of our National Million Hearts Initiative, our Million Hearts team, and our Million Hearts partners across the US. So this first slide is a slide that I think will open us up appropriately. And this is provisional mortality data from the CDC and Mmwr, and for the year 2020. And it's just a reminder that even in the midst of a global pandemic, that the number one cause of mortality in the US remains heart disease. Now, COVID was the number three cause of death in 2020, but the impact of hypertension in terms of population attributable risk remains a very significant population burden. And we see similar data from this 2020 data also in recently published data from 2021. When we look at this mortality data, though, we need to recognize that during this year of 2020 of the pandemic, that age-adjusted death rates increased by almost 16%. And we saw significant disparities in death rates, highest in non-Hispanic Black persons, non-Hispanic American Indian and Alaska Native persons, and the COVID-19 death rate was highest among Hispanic persons. Next slide, if you would. We'll be talking today about hypertension and the importance of vaccines. We know the influenza vaccination remains a critically important strategy for not only preventing influenza-related illness, but for cardiovascular disease prevention. In fact, the American Heart Association and American College of Cardiology have given this a Class 1 recommendation for secondary cardiovascular disease prevention. So these are people with established heart disease and those with the highest risk of heart disease. There's data that shows that within a week of influenza infection, there's a 6-fold greater risk of having a heart attack. We know that viral illnesses like influenza, but also like COVID, cause systemic inflammation. And through this systemic inflammation can increase various cytokines in our body. These cytokines can cause destabilization of cholesterol-laden plaques in our blood vessels. When we think about strategies like influenza vaccination, we should liken them to other strategies for heart disease prevention, like taking a cholesterol medication or smoking cessation or optimally treating blood pressure, because getting a flu vaccine reduces the risk of cardiovascular events in a similar range as these guideline-directed medical therapies. Well, another flu season will be around the corner. And with this upcoming flu season, we need to be ready. We need to be ready to provide appropriate messages that are about the safety of vaccinations. But these are messages that absolutely need to be focused on trust and partnered care between our clinicians, our clinical teams, and our patients. And importantly, as we try to improve rates of vaccination, we should focus on individual communications and trust, but also the importance of health system and team-based approaches to care. Next slide. This is data that I'll call BC, before COVID, and it also comes from the CDC. This is from the year 2019. the 2018-2019 flu season. And unfortunately, despite having effective and safe vaccines, less than 50% of American adults received a flu vaccine during this flu season. Now, if we look at the impact of influenza on both disease, hospitalization, and death, recognizing that each and every flu season, these levels will wax and wane some. But in this flu season from 2018 to 2019, there were tens of millions of flu-related illness, tens of millions of flu-related medical visits, hundreds of thousands of flu-related hospitalizations, and tens of thousands of flu-related deaths. So we absolutely want to be ready for the next flu season, especially recognizing that there'll be a confluence of influenza and ongoing COVID-related disease. Next slide. This slide depicts a meta-analysis published in the Journal of the American Heart Association. And as I mentioned earlier, that getting a flu vaccine is a strategy for heart disease prevention, just like working with your patients to stop smoking, treating their blood pressure, their diabetes, or their cholesterol. And then in this meta-analysis that looked at over 200,000 participants of adults followed for almost 20 months, there was a 25% reduction in all-cause mortality and an 18% reduction in cardiovascular mortality and a 13% reduction in a composite of cardiovascular events, as well a reduction in a trend towards a reduction, we'd say, in heart attacks. Unfortunately, I'm a cardiologist, I'm a preventive cardiologist, but if we look across the medical care spectrum, cardiologists are the least likely of all medical professionals to stock flu vaccine in their clinics. I continue to care for patients at Emory University in the Emory University Clinic, and in our preventive cardiology center, we have protocols that are well established for each and every patient. In fact, our medical assistants, when they're checking into patients, are asking about whether these patients are up to date with their vaccines. And there's follow-up with our nurses, and then of course with our physicians. But this is an important part of our day-to-day care of each and every patient. Next slide, if you would. Well, first, before we talk about the share model, and this is from the CDC as well, I do want to mention that we see significant disparities in both access to influenza vaccination and also influenza-related hospitalization. I mentioned that less than 50% of all adult Americans receive a flu vaccine every year. But if we look at the data more closely, there was a paper published in JAMA Cardiology in 2020, the first author, Grandi, and it looked at various social determinants of health and age-related populations in younger adults aged 40 to 64, non-Hispanic Blacks, low income, uninsured, patients with lack of usual care, and those with a high school education or less. There was a continuum of lack of getting a flu vaccine. And so if we looked at this population at higher risk, a more vulnerable population, those with two or more of these factors, these social determinants, had a 2.5-fold lesser chance of having a flu vaccine. So we must think about both barriers at the level of the patient, the clinician, the community, but also the health systems, and also solutions that are multivariable. The SHARE model, this is a nice acronym to think about. So share the reasons for vaccination, reasons that include protecting yourself, but also your family and your community from infectious diseases and the consequences of infectious diseases. So community immunity, very important. Highlight the positive experiences. I myself get a flu vaccine every year. It's all about that safety and trust and communication and a partnered care relationship. Absolutely address patients' questions. We need to do a lot of listening. Listen first, understand their questions and concerns, and address those. Don't judge, but certainly listen and talk, and hopefully come to a team-based approach to care. Remind patients that the flu vaccine protects them and their loved ones, and explain the potential costs of flu-related illness. Those costs, of course, can be at an individual level, but people missing work, people missing events with their family, and unfortunately, the greatest costs can be costs of human lives. Next slide. Well, we've been in the midst of a pandemic now for the past 2.5 years. This slide depicts the multiple impacts of the COVID-19 pandemic. Of course, the impacts of COVID-related illness itself, but the secondary consequences, most of this unintended on day-to-day care, the consequences on patients keeping up with their regular medical care, their hypertension control, their blood pressure medications. We have adapted and adopted into telemedicine and telehealth in many spaces, but we've also found that many of our patients don't have home blood pressure cuffs, a great deficiency and a significant need and gap, especially when hopefully in the future, we'll have the greater opportunities and abilities to deliver these telehealth and telemedicine models through team-based care. The pandemic's also had consequences that are ongoing, related to care, but also to our economy and to the mental health of our population. Next slide, if you would. This last slide here is just a reminder. This is from an MMWR pretty soon after the onset of the COVID-19 pandemic. And on the left-hand side of this panel, you see that shortly thereafter, within 10 weeks of the onset of the pandemic, many health systems and emergency rooms were seeing fewer patients for heart attacks, strokes, and high blood sugar. Now, the reason that these patients weren't being seen was not that these events were not occurring, but that many patients were concerned or frightened to utilize regular health system resources. And on the second side of this panel here, you see that hospitalizations were 6 times greater and deaths 12 times greater in those with COVID-related illness who had underlying chronic disease conditions such as heart disease, lung disease, or diabetes. And although this paper was published early on during the pandemic, it is highly relevant today as we now have COVID vaccine boosters, and we certainly have the likelihood of the confluence of COVID-19 and influenza coming this fall. So with that, I thank you for your time and attention. I'm going to hand off here to Dr. Yabo and look forward to our discussion, importantly, in addressing your questions and concerns.
Thank you so much, Dr. Sperling. That was beautiful, and I think a beautiful setup for Dr. Yabo. So I want to introduce Dr. Yabo Beysolow, who is an acting pediatrician and an Association of Immunization Managers immunization consultant. She is one of our partners that works with us to develop our Total Health Champions series. So welcome, Dr. Yabo.
Thank you so much to Kristen for that warm introduction, and Dr. Sperling, thank you for such a great segue and a great overview about COVID and flu vaccinations, the importance of vaccinating people with hypertension and chronic heart disease. You touched on COVID and flu, and we'll discuss the others. So we can move on to the next slide, please, Kristen. I had the opportunity to work also at the CDC for several years in the Immunization Services Division, and every year we put out the immunization schedules for adults and for children. And this is the immunization schedule for adults that is put out annually, and the recommended vaccines are listed in the first column, and the next columns depict by age who's eligible. Some vaccines in the Yellow are for everyone who meet that age requirement. And those in the purple may have a particular risk factor, et cetera, that would necessitate them getting vaccinated at that age, such as being immunocompromised. And there's some where you will need to discuss with your physician if it's appropriate for you to get that medication that's in like the light blue. So just running down that first column, Dr. Sperling already did a great job talking about flu, but just to remind you that the flu shot is what is recommended for most adults over 18, unless they have a contraindication. The live nasal flu spray that healthy people can receive, you can only receive that up through the age of 49. Over 50, you would have to get the shot. It was only approved for those under the age of 50. There's also the tetanus booster. You're all aware of that you should be getting a tetanus booster every 10 years as an adult. And so that is recommended as well. MMR, that stands for measles, mumps, rubella. Some of these names I'm calling, you're probably thinking, well, I haven't heard of these. Are these still around? And unfortunately, a lot of illnesses are still around and they pop up at different times. There may be outbreaks in certain parts of the country. If someone's unvaccinated and contract that disease, they can then spread it on to others who are also not vaccinated. So measles, mumps, and rubella, you want to make sure that you're up to date on that vaccine as well to protect against those 3 illnesses. As you know, measles causes the rash all over, and mumps can cause swelling of the jaw area and for men over their testicular area as well. Varicella, that's the medical term for chickenpox. You want to make sure that you're protected against chickenpox, even as an adult. If you never received the vaccine, you can get chickenpox, especially if you're around little ones. The zoster vaccine, everyone over the age of 50 is recommended to get 2 doses of zoster vaccine. That's the shingles vaccine to prevent that very painful shingles illness that can occur. HPV, you may have heard of that. Human papillomavirus is not only for teens. It can also be given up through the age of 45. If you're interested, you can speak to your physician about getting protection. HPV, as we know, is the leading cause of cervical ovarian cancer in women. It's also the leading cause of oral cancer, anal cancer in women and men. The other vaccine we want to highlight, there are 2 actually in this category that prevent pneumococcal disease. What does that mean? Pneumococcal illness can lead to pneumonias, which can complicate flu infection or COVID infection, et cetera. And now you have a double whammy where you have 2 respiratory illnesses at one time. So you want to make sure that as we approach this upcoming flu and COVID season, the continuing COVID pandemic, that if you're age eligible, that you get it and you recommend your family members who are also eligible to receive the pneumococcal vaccines. There are ads now on TV for PCV 15 or Prevnar 15 or Prevnar 20 and the pneumococcal polysaccharide vaccine. So these are all very important vaccines to receive. Hepatitis A and hepatitis B are viruses that can cause liver disease. Hepatitis A, you can contract from contaminated food or water, can lead to yellowing of your eyes, jaundice as we call it. Hepatitis B can cause chronic liver disease. So it's very important that you also ask your physician, your healthcare provider, am I eligible for these vaccines? Have I had them before? When can I get them if I have not? Meningitis, some of you may have heard there's a meningitis outbreak ongoing right now, even in Florida, among certain populations. And we want to make sure that you are covered with, there are 2 meningitis vaccines currently. One protects against the 4 strains, ACWY, and one called meningitis B. And then lastly, Hib vaccine. Mostly we see that being used in children, but it's also used in adults who have immunocompromising conditions. For example, someone who no longer has their spleen or someone with sickle cell disease. And then for those over the age of 65, definitely the flu and pneumococcal vaccines. So we can move on to our next slide. So this slide is just really letting us know that chronic hypertension increases your risk for heart attack and strokes. It can also lead to chronic heart disease and congestive heart failure, as already elucidated by my colleague, Dr. Sperling. And so there is another, on the next slide, another table that CDC puts out annually. And this one really depicts vaccines that are recommended based on your underlying medical condition, and includes medical conditions such as people who are immunocompromised, either because they have a disease such as cancer or they're on medicines that will cause them to be immunocompromised. People living with HIV, people who do not have a spleen, like we talked about sickle cell disease, people with end-stage kidney disease or on dialysis, chronic liver disease or diabetes. So under each column heading, there are specific vaccines that are recommended. And just wanted to highlight a few for people, adults with heart or lung disease. That is the 5th or 6th column on the screen there. And you can see in yellow the vaccines that are recommended. And it's the 1 flu shot annually, as Dr. Sperling mentioned, your tetanus booster every 10 years, your measles, mumps, rubella, and chickenpox vaccines if you're not previously vaccinated, shingles vaccines beginning age 50 years old, HPV vaccine, pneumococcal vaccine, Hep A, Hep B, meningitis if you have another risk factor, or if you're traveling to an area that has higher rates of meningitis. And then the hip vaccine, as we mentioned, for someone who's immunocompromised. So these are 2 great tools that you can share in your community with providers, letting everyone know that all adult vaccines are recommended for people with hypertension, chronic heart disease, and for adults in general. Vaccines do not just stop in childhood and adolescence. We continue them in adulthood as well. So now let's turn our attention to how well we're doing with vaccinating our populations with regard to COVID-19. Dr. Sperling mentioned this a little bit already. We wanted to share this table from the CDC. It's updated weekly, and it shows the proportion of people in various ethnic groups who are fully vaccinated. So for example, if we look at the dark blue bar for the Black population, we see that there's a high percentage compared to the gray bar, which shows the total people eligible to be vaccinated in the Black population. So there's not much of a gap there. And that basically tells us that we are narrowing that gap, that most of the people in the Black population who are eligible for vaccination have received at least 1 dose of vaccine. They're considered fully vaccinated, but we're not yet talking about booster doses. We'll get to that in a minute. So though we're seeing some catch up in the various racial and ethnic communities in terms of being fully vaccinated, we continue to see some mild disparities. One of the concerns is that we continue to see an increase incidence of cases, hospitalizations, and deaths in the African-American, American Indian, or indigenous populations, communities, as well as in the Hispanic or Latino communities as compared to their white counterparts. 1.5 times more cases in the Hispanic and American Indian populations. The rates of hospitalizations are 2 to 3 times higher in our African-American, Hispanic, and indigenous populations, as well as the death rates. So that is why we continue to encourage you to spread the message about the importance of COVID-19 prevention through vaccination, continuing to wear masks, continuing to social distance in large settings, and definitely mask wearing in indoor settings, et cetera. So all the tools that we have in our toolbox to ensure that we continue to protect our communities against COVID-19. We also wanted to share information here about the rates of COVID-19 deaths by vaccination status in persons 5 years and older. As of June 2022, people who are not vaccinated were nearly 3 times as likely to test positive for COVID-19 as compared to people who had had at least the primary series of COVID-19 vaccination. So that's a big difference. They're nearly 3 times likely to test positive if you're not vaccinated. And then what about booster doses? We're continuing to see some lags there in booster rates by racial, ethnic status and group. And we're seeing that especially for the Black population, Hispanic, Latino, and Indigenous American populations, we still have a lot of work to do in improving the booster dose rates. And again, this table shows in green the percentage of that particular population who have received a booster dose, and in yellow, the percentage who have not. So for example, again, if you look at the Black population eligible for a booster dose, 12 years and older, about 44% of us have received our booster doses, but 56% have not. So the messaging now needs to be concentrated on getting your boosters. Remember, in the US, people 5 years and older are now eligible for a booster dose anywhere from 4 to 5 months after completing their primary vaccine series, and that depends on which vaccine they began with. Next slide. And why are we talking about this? Because again, the data is there and it shows that people who've had in that dark purple, just concentrate on the bars at the very bottom for a minute, where it shows that among people 50 years and older who are not vaccinated, there were 29 times more at risk of dying from COVID-19 compared to someone who had their primary series and 2 or more booster doses. And then people 50 years and older who are not vaccinated had a 4 times higher risk of dying from COVID-19 compared to people who had a primary series and 2 or more of the booster doses. So it's so important that, again, we send the message home that it's not only important to get 1 dose and say, oh, I'm vaccinated, but to stay up to date. That includes getting your complete primary series and being up to date on your booster doses. Very important to, again, spread that message. I won't spend as much time on here because I know Dr. Sperling already discussed a lot of the disparities that we continue to see, and this has been for decades, not only in the last 2 flu seasons, but even prior to the pandemic, where we see great disparities in flu vaccination rates amongst adults from African American and Hispanic and Indigenous American populations. And for some of the reasons that we're still seeing with the disparities in uptake for COVID-19 vaccine in some of these populations. And until structural racism in healthcare is acknowledged and addressed with an open mind, as well as attention placed on improving some of those social determinants of health, such as access to healthcare, decreasing someone's exposure to illness due to where they live, work, or play, and socioeconomic status, will continue, unfortunately, to see these disparities. So all of this needs to be addressed in totality as we tackle how to share those models, as Dr. Sperling accurately discussed, such as the share model, when you're having those one-on-one conversations with patients and you're listening, building that trust, and then sharing your side of it in a non-judgmental manner. But again, it may take several of those conversations to get someone to the yes versus I'm still thinking about it phase in their decision-making. So with that, I will end there and turn back over to Kristen. Thank you, Kristen.
Thank you, Dr. Yabo Beysolow. Thank you so much for that in-depth review of all of the adult vaccinations that we need to be aware of, especially for patients who are living with chronic hypertension. I want to make sure that we have time to go through our microsite and also be mindful that those particular charts and those tables that Dr. Yabo so eloquently went through, those are available on the CDC website. And so once we get the microsite feedback from you guys and then do a comprehensive review and revision editing session of the microsite, we will definitely be making sure that there are links available so that you can access those tables. You can take them back again to your communities and to your providers so that you know where you stand and you can remain up to date on your adult vaccination. So really quickly, just to give you a little bit of background on the total health webinars and microsites that we've done so far, we have done chronic kidney disease, Black maternal health, the pandemic's toll on mental health, and cancer. The cancer microsite just got completely revised and finished, and so that will be pushed out via our social media channels and our Health Champions newsletter and our NMQF newsletter as well. So if you would like to get on that listserv, please don't hesitate to email us at shc@nmqf.org. So I am going to stop sharing the PowerPoint so that I can take you straight to our microsite draft that we have developed for hypertension and vaccinations. So with each of our microsites, we really want to drive home that this is a more in-depth version of this webinar. So there will be several sections that you can click on to skip to that particular section to get the education that you're looking for. So we're defining hypertension. What is chronic hypertension? What is hypertension in general? And what is chronic and what does it lead to? What are those lifestyle drivers of hypertension? And then inequities in health outcomes related to hypertension, and how do those inequities play a role across racial and ethnic demographics, subpopulations. And then we have a specific focus on COVID-19 and flu, obviously, and then all adult vaccinations. Again, I said we will have a patient perspective video, and so we will be adding that to our microsite. We always have a section in each of our microsites for additional resources, whether it be after each of the subsections or at the very end. For this one, it made more sense to have it at the very end. And so you can go to American Heart Association, CDC, NIH, several different resources, external resources to get more information should you need it. And then we always place this webinar recording on our microsite just so that you have somewhere to go back to in perpetuity. And it will be archived on NMQF's YouTube page as well. And it will be shared through all of those channels that I just talked about, both of our newsletters and our social media spaces. And then we have our sources. So just in case you want to fact check us, we don't mind at all. We have our sources for you to go back to. So really quickly, I will walk you through what each section entails and what it looks like. So you already know we have our definitions and what healthy and unhealthy blood pressure ranges are. What we like to do is make sure that there's a mixture of definitions and written education and information, but also graphical representations of the educational information and videos. So one of the things that we've been able to do is pull from the Million Hearts initiative with the CDC that Dr. Sperling is the executive director of. They have developed some excellent materials in their Live by the Beat campaign, I believe it's called. And so we embedded some of those videos here because they are culturally relevant and appropriate, and they address some of those lifestyle drivers that really drive chronic hypertension. So diet and medication taking and exercise. And then smoking is a large risk factor in cardiovascular disease and hypertension. And then, of course, we go into the inequities in hypertension outcomes and what that means across populations. And there's a particular study highlighted in here about disease prevalence, awareness, treatment, and control across white, Black, and Hispanic patients living with hypertension as well. And then the drivers of inequities in hypertension, right? So Dr. Yabo already mentioned systemic racism and racism in healthcare, but also there's, the pathophysiology, social determinants of health, there's political determinants of health, and systemic determinants of health, and adverse healthcare. And then having, this perfect storm of hypertension and CVD there. And we have some of those factors really delineated within this informational section here. And then we go into Dr. Keith Ferdinand, who is an incredible voice for cardiovascular disease and cardiologists that we work with on a regular basis, helped with developing the study that came up with all of these drivers and factors. And then again, hypertension and COVID-19. What are your risks for hospitalization and mortality if you are living with chronic hypertension and you get COVID-19, or if you get the flu? And then our adult vaccines table that Dr. Yabo went through that really delineates if you have heart or lung disease, which vaccinations you need to be thinking about. those additional resources that I mentioned. We have a placeholder for our perspective and our webinar recording, and then our sources. So with that, we are going to go into our interactive portion of the webinar. So I would love for you all to make sure that you are transparent in your feedback. My colleague Chinny will be helping me take notes for this portion, and I am going to share my screen for the Jamboard so that we can see all of the responses. But first, we are going to have a poll on the topics that you'd like to see from future NMQF webinars, things that we can explore. So I am going to launch that poll right now, and I will give you some time to respond to that so that our internal team, not only of course at SHC, but at NMQF, can take a look at whatever you think is vitally important that we can discuss, not only on our last Friday of the month, but in the other Fridays as well throughout the month. And panelists, feel free to engage in these poll questions and this feedback portion as well. So we've got just some of the answers that you can choose from. We've got clinical trials, vaccines, our cancer stage shifting initiative, CBC Health Brain Trust. For those of you who don't know what CBC is, it's Congressional Black Caucus, brain health, health policy, communication strategy, and social media outreach, and specifically talking about like communications, prioritizing historically excluded communities, our For Your Health news platform, AI and technology in healthcare, or obviously you have a space for others. So if you have something that's not listed here, please feel free to choose that other option and enter it into the chat, and we will be able to download the chat after this webinar and have all of that feedback. I will give you a few more seconds to answer. Just got my stopwatch here. All right, I think everybody has answered that will. All right, it looks like vaccinations, health policy, clinical trials, and brain health are in the lead. So we will take this information back to our team so that we can begin developing webinars on these topics. And there's the shared results. Thank you all who participated. All right, so I will stop sharing. Okay, so when we talk about our, webinar, this is what we're talking about today in the microsite that you just got a chance to preview. I wanted to ask you, who would you share this hypertension microsite with? I'll go ahead and launch that poll. Would it be your colleagues, your family and friends, patients, or social media audience, or some combination of all of these? And we want to make sure that as many of the right audience, or I won't say right, but appropriate audience that we can reach those individuals, and we can reach them with the appropriate linguistic style, making sure that we have all of the information that they need as well. All right, it looks like the answers are slowing a little bit. So I will end the poll and share the results. So colleagues, then family and friends, and social media audience on any platform, and then patients. So we will definitely take this into regard as we continue to refine and edit the microsite. So I will go to the next question. And again, Chinny will be monitoring the chat for your responses. So feel free to be transparent with your feedback about our microsite. So do you notice any vital information missing from the microsite that should be included? Is there anything in the microsite that's not there that you think we should include, especially for patients who are living with hypertension or chronic cardiovascular disease? Please don't be shy. We welcome your candor. I will give everyone a few more seconds to enter into the chat. And please feel free to gather all of your questions as well for the panelists for the Q&A box. Well, if there's no feedback, I can't believe it, but I guess we did a really good job of incorporating all that needs to be in this microsite. But if you have something else, please, please don't hesitate to let us know and put it in the chat box. Again, I want to make sure that you guys know you are not on audio or video. You don't have those capabilities. So please add your comments to the chat box. So I will move on to the next question. What additional challenges? Oh, we have a question for Q&A. Oh, perfect. These are perfect questions for our Q&A portion. So let's get through the interactive microsite. It says that the chat box is disabled. Oh no. Chinny, can you help us out with that to make sure that everyone is able to enter into the chat box? I wonder why that is. Please forgive us. Keiko, who is so amazing, she is not here today, but she usually runs all of NMQF's webinars. So we are doing the job together, my colleague Jenny and I. So hopefully we're not doing too bad.
I'm not
I'll
sure
let you
why, because I can see everyone. I thought I can see everyone's responses, but I'm just gonna monitor the Q&A as well. So
okay, perfect. Thank you so much, Chinny.
no worries.
So go ahead and put your, people are saying the chat is disabled. It may be a function that we missed on setting up this particular webinar. So you can go ahead and use the Q&A portion or the Q&A box, if you will, if your chat is disabled. Okay, so for this particular question about the microsite, what additional challenges from vaccine preventable diseases exist for patients living with hypertension? Is there anything that we as a panel or that we as a team have missed that you'd like to see that presents an additional challenge? It could even be related to the social, political, or systemic determinants of health, and maybe there's something that we missed. Again, you can use the Q&A box if your chat is disabled. Please try again. It looks like I tried something to see if attendees can chat with everyone. So try that again, everyone, in the chat box. Again, my apologies for that little hiccup. Also, if we, outside of our Friday NMQF webinar poll that we discussed with our very first Zoom poll today, if there's something in total health that you want to see us discuss as a team, as an organization, please feel free to do so. Please let us know in the chat or the Q&A box. And you can also, again, send us an email at shc@nmqf.org. Okay, yay, it's working. What about weight and food choices due to various income? I think that's vitally important. I think talking about food insecurity, talking about food deserts and food swamps, we can certainly add those to the microsite as well. When we talk about the diet portion of those lifestyle drivers, there's something to be said about the way the system sets up access to food resources and the access to food as well, and nutrient-dense foods. Anything else? All right, I'm going to move on to our fourth question. So we know a lot of the risk mitigation tactics that we can take, but in addition to all those, we've got good hand hygiene, masking, physical and social distancing. What additional risk mitigation measures can patients living with hypertension take to reduce the risk of contraction of infectious diseases like flu or COVID-19. And again, we know that, some of these things are speaking from a highly privileged place, if you will, especially physical and social distancing, when there are essential workers who have to go to work every single day and work in crowded conditions. We completely understand that. So if you have any other risk mitigation tactics, we'd love to make sure that they're highlighted on our microsite and that they are developed within our other resources. So just a tidbit that I forgot to mention, on our microsite, we have all this detailed information, and that information is then pared down into flyers and infographics with the partnership of our AIM and iREACH team to disseminate across communities and providers and clinicians and health systems alike. All right, I don't see anything else coming in. So last question, how can our team improve the cultural appropriateness of this microsite? Yes, take medication as prescribed. We do have a medication taking lifestyle driver video on there as well. So when you think about, information being culturally appropriate for an audience, where do we fit on that spectrum? And if we can improve, how can we do that? You guys are a shy group today. Kidding. I know it's Friday and it's the summer and it's hot in most places. So I know it's super hot here in the South. So I want you guys to not only be vaccinated, but stay hydrated and cool. So if you have any other feedback, don't hesitate to drop it in the chat as we move to the Q&A portion. So I will go ahead and move to the Q&A portion for our panelists, Dr. Sperling and Dr. Beysolow. I'll pull this up so that we can answer those questions live. Oh, we have some in the chat. Ensure that it is more than one language and accessible to PWD. People living with disabilities, I believe is what you're describing. Georgia Simpson, thank you so much for that tidbit. Yes, we will definitely make sure of that. So our first question, should we expect to continue to receive COVID-19 boosters going forward? And I assume they're asking like in perpetuity. Dr. Yabo, Dr. Sperling, did you want to comment on that?
Sure, I can begin. At this time, because of the variants that continue to emerge, and really it's because we don't have a huge percentage of the world population vaccinated. And as such, the virus learns to evade or basically skip past our immune system and morph itself so that we don't basically get ahead of it. And so that's why we continue to see variants. We're now dealing with the Omicron variant. As you're all aware, BA.5 is now greater than 70 to 80% of the variants in the US. And because of that, we will continue to need boosters for the time being. The decision that is ongoing right now is whether everyone who's eligible to get a booster should get a second booster and not just those 50 and older. So that's the discussion right now by CDC and the scientists. Or should we wait for a booster that also has a specific target against the Omicron variant, which may be out later in the fall? So that's the discussion that's being had right now. We should find out something in the next few weeks because we are getting close to the flu season. We want to make sure that, as Dr. Sperling mentioned, we don't have a twindemic where we have both flu and COVID circulating and people are not well protected. So hopefully we'll have an answer to that decision in the next few weeks. But I'll turn to Dr. Sperling to see if he has something more to add.
Yeah, thanks. And of course, my comments here would reflect my specific comments and not those of the organizations I work with, work for, or serve. But completely agree with Dr. Yabo here. Over the past 2.5 years, we have had knowledge in evolution, science in evolution, and recommendations in evolution. And so we are in the here and now right now, and BA.5 is the dominant variant, and it is likely and hopefully that we will have other vaccines that will be more variant specific. There is a lot of discussion about that scientifically, and I think right now we still have opportunities to vaccinate those in the population who not only have not had their 1 booster or 2 boosters, but just even the first sequence of COVID vaccines. And we know those are, as Dr. Yabo showed quite well, extremely protective against hospitalization and death. However, we know that this will continue to be a dynamic situation. And so all we can, the way we can approach it is often at this time, this is what the science supports, this is what our conversation supports, but it comes back to the safety and trust. And I know we're talking about here the importance of being champions for total health. And so would hope that each and every one listening to this important webinar recognizes that you're a champion, and you can be a champion with your patients, a champion for your family, a champion in your community. And when we have many champions, then we really are stronger as a nation.
I agree. Thank you, Dr. Spurley and Dr. Beysolow. I really think that this whole champions thing, just creating that kind of each one teach one mentality and that everyone can reach someone is a really important message. So thank you for highlighting that. Our next question, with so many vaccines, is there one that should be a priority? I think that kind of cripples a lot of people, right? There's so many I need to get. What is priority?
Great question. And I always turn this back as I put on my pediatrician hat. Just think of our babies. You know, in the first couple of years, we vaccinate them with vaccines pretty much every 2 months. So by the age of 2, they've had the majority of vaccines to protect them against all these diseases that we shared with you today. So it's so important that as adults we recognize that, yes, unfortunately, there's no priority. All of those illnesses are just as important as the other, and we do need protection from all of them. Now, do you need to get all the vaccines on the same day? Not necessarily. You can work with your healthcare provider and get vaccines maybe over the course of a year to make sure you're caught up. But the priority remains flu for the upcoming flu season, COVID-19 vaccines, staying up to date, getting your booster vaccines to make sure that you're protected against those 2 illnesses and the pneumococcal vaccine if you're age eligible. Thank you.
Thank you so much. And then the last question that we have in the Q&A box, can you all talk about monkeypox briefly? So I will let Dr. Yabo Beysolow, she does an amazingly eloquent job of describing the situation right now. So I will let her give a few remarks.
Sure. So with monkeypox, we are in a situation where it has been declared an emergency by the World Health Organization, and just reading through the news today, it's also being declared an emergency in some states. Monkeypox is also caused by another virus, but it's not new. This is a virus that has been ravaging some countries in the rest of the world, in particular in West Africa and in the Congo, for decades, and it has caused and continues to cause death there. What we're seeing now is an outbreak outside of those regions with over 16,000 cases around the world currently. And in an attempt to make sure it does not continue to spread, the World Health Organization has declared it a state of an emergency. What we want you to take away from this conversation is that for the most part, majority of us are not at risk. Monkeypox spreads through very close personal contact with someone who has the illness, such as maybe sharing a bed or sharing the same living quarters where you may be sharing towels, sheets, etc. with that person. So it's spread through that way. We want to make sure that people understand this is not a sexually transmitted disease. it should not cause us to stigmatize any one group of people and say that this is a disease only for men having sex with men, etc. It is not an STD. Anyone could potentially get monkeypox if they're in those kind of close living conditions over a prolonged period of time with someone else who has it. There are a few cases right now in the United States, and these are being watched very closely. The CDC has sent out what we call a health alert notice to all providers across the United States to be cognizant and to be alert of what are the symptoms. They look very much like, say, chicken pox. Many of you, I'm sure, I've never seen smallpox, but smallpox lesions or pox lesions where there are water-filled bumps, but there can also be variations to how the rash looks. And so all providers now across the country have their antennas up to look for the symptoms. Symptoms can be fever, headache, chills, and as well as the rash. So it's very important that if you are concerned about that, you talk to your healthcare provider. But we just wanted to share those takeaways. There is a vaccine, there are actually 2 vaccines that are currently being made available in the United States for people at high risk. So for example, someone who has come into contact with someone with monkeypox in order to prevent them getting monkeypox, or someone who is working with the studying of monkeypox in the lab, etc. So there are 1 million doses of vaccine, as I read this morning, that are currently being made available. So I'll stop there and see if Dr. Sperling, anyone else has any further information.
I would say nothing to add, but just learned a lot from listening to your comments there. Thanks so much for sharing them. And this is another situation where it clearly will be dynamic. For clinicians, we should be very aware. And as you mentioned, there are certain states like Georgia, where I live, where we're seeing increasing rates of this illness. So hopefully we can approach this similarly to, I know with smallpox, they talked about strategies to address it in terms of population health and public health. And I think there are conversations ongoing similarly related to monkeypox.
Yeah, thank you, Dr. Beysolow and Dr. Sperling. I just want to reiterate that we won't stigmatize this illness, and we at NMQF will keep a lookout for how we can continue to provide additional information for our audiences. And with that, I want to thank all of you for joining us today, especially our panelists. Thank you so much for all of your feedback. We will definitely be taking that microsite feedback and editing our landing page, and then this recording will be made available probably by Monday. So have a great weekend, everyone. Thank you so much. Bye.
Thank you, everyone. Bye-bye.